Hello, welcome to Disaster Mental Health and Trauma, Module 1. This is part of the training series for emergency personnel, which is produced with cooperation from the Pennsylvania Department of Human Services along with Millersville University. My name is Mark Filizzi, and I am a professor in the School of Social Work at Millersville University of Pennsylvania. And this trauma overview will give you information regarding trauma and traumatic reactions. As I said, I teach in the School of Social Work at Millersville University of Pennsylvania, and I'm particularly interested in this topic for first responders and emergency personnel, as I've taught disaster mental health and trauma since 2014 in the Center for Disaster Research and Education at Millersville University. I'm certified in trauma-focused cognitive behavioral therapy, and I've worked with a number of first responders over the past 30 years, and I've worked on crisis teams in education and in community mental health. So we'll start by discussing what trauma is and what trauma looks like. Trauma is a psychophysical reaction to an event which is experienced as overwhelming. So the person who experiences it feels overwhelmed. And it also arouses a strong emotional reaction in those who are exposed to the trauma itself. So when we say psychophysical, obviously it affects your emotional thought, it affects your cognitive thought, your behavioral thought, and it can affect your physical reactions as well too. So both mind and body are involved in trauma and traumatic reactions. There are events which cause trauma, and obviously, and there are occurrences that profoundly disrupt the ordinary and or normal or regular course of life. So it will affect you in many ways, obviously, and they can be events that most would be considered as extraordinary, such as a fire, a mass murder, a mass shooting, something along those lines. Or they may be subjectively perceived as distressing or shocking. So the loss of a home, the loss of income, an accident, the death of a loved one, a colleague, a pet. And it's the individual and the community or the nation's perception which is critical. So you may not think it's traumatic. However, the person who experiences it feels as if it's traumatic. Many times when you're working with traumatized people, you have to understand their reactions and why it is traumatizing for them. Your reaction is not important if you're working with them. It's their reaction which is affecting them. So there are traumatic events that affect communities and nations and the world itself. So natural disasters, uh, pandemics, tsunamis, floods, hurricanes, earthquakes, and human-made events such as wars or terrorist acts or accidents or industrial accidents. There's other examples of traumatic events or experiences on a large scale. Suicide bombings, terrorism, airport bombings, things of that nature. Um, Long-term issues that have been in the society for a while, so such as prisoner abuse, trafficking of women and children or vulnerable populations, school shootings, racism, sexism, ageism, and these effects of trauma build up over the ensuing years. So to understand and comprehend traumatic reactions, which we will do later in this presentation, you have to understand where trauma comes from yourself or your coworkers or people with whom you're working, survivors. So we need to discuss what trauma is and what causes traumatic reactions. So we'll get to that presently. So we start with individual trauma. What is individual trauma itself? So we said that trauma is a psychophysical reaction, and Rothschild says that trauma is a psychophysical experience, even when the traumatic event causes no bodily harm. So it may not harm you. Simply by viewing something that causes trauma can cause a tremendous reaction within you, a psychophysical reaction within you, but it won't hurt you. You won't have a wound per se, but you will have internal wounds. We react to these traumatic reactions, and there's a list here. And many times we can become traumatized by hearing about violence and or abuse. And I'll get to that in subsequent presentations. So a vicariousness of trauma. So simply by witnessing trauma, it can affect us greatly. I am certain there were people in 9/11 at Ground Zero who were going to work and were not physically injured by any of the falling debris or anything along those lines, but simply by observing the horror that was unfolding in front of them, obviously traumatized them and caused an internal reaction. So we start by discussing how trauma affects the brain itself. And we start with the limbic system, which is part of the brain. It really controls hormonal reactions within the brain, chemical reactions within the brain. Excuse me, the limbic system is composed of 4 organs within the brain: the thalamus, which relays information; the hypothalamus, which gets us back to balance, homeostasis, we call it; the amygdala, which processes emotion; and the hippocampus, which the hippocampus's job is to put memories into sequence. It's your file organizer, if you will. So these 4 organs, the hypothalamus, the thalamus, the amygdala, and the hippocampus, all play a part in trauma and traumatic reactions and how we process that trauma. So we know the brain responds to external influences. We see something, we take it in, we put it into our memory, and remember that as something that we don't want to remember, or something that can be pretty traumatic to us, but it's in there. It gets organized into the file, and we react to it. So we know the brain controls the nervous system, and it's linked to other parts of the body. So in the limbic system, what happens, the amygdala is sort of the gatekeeper, if you will. So the amygdala is a walnut-shaped little organ buried in the bottom of the brain. And what happens, the amygdala is that gatekeeper, it's the sentinel. It becomes activated whenever a traumatic issue or traumatic situation occurs. So the amygdala sees it and it kicks into gear and basically tells the rest of the brain, get to work and or shut down. And I'll explain what I mean by that. Years ago, in working in emergency response, excuse me, we would ask a survivor, tell us what happened. And they would say, I can't. I don't know what happened. A thing unfolded in front of me, and I don't know what happened. And that was because the amygdala became activated and shut down other portions of the brain, namely the hippocampus, that file organizer that takes things in and puts those pictures that they just saw into a file, if you will. The amygdala shuts that down. And what the amygdala does, it kicks you into the fight, flight, faint, or freeze reaction. And we'll talk about that in a second. So the amygdala is the first organ in the brain, if you will, that sees the trauma and tells the rest of the brain to either shut down or get into action. Get into action would be the hypothalamus. The hypothalamus produces cortisol, which brings us back to homeostasis. The reason we have cortisol, it's a hormone in the brain. The reason we have it, it's to lower your blood pressure, lower your heart rate, bring everything back to normal, your breathing rate. And that's perfect. However, too much of cortisol can be a bad thing, and I'll talk about that in a second. So let's go back to the amygdala. It sees the trauma, causes you to react, tells other parts of the brain to shut down. So in trauma, the amygdala is the gatekeeper, that sentinel, which kicks off everything. So again, the amygdala says to you, run, fight, freeze, or faint. Okay. And the amygdala itself stores emotions and reactions to traumatic events. It's present at birth. It's the part of the brain at birth that keeps you alive, believe it or not. The interesting thing about this, your amygdala is present at birth. It's active at birth. If I asked you today, what's your first memory? You'll probably go back to when you were age 3, maybe age 4, maybe age 5. You can't remember anything before that. That's because the hippocampus, which puts everything into order, which takes pictures of what you're seeing and puts them into your file, the hippocampus isn't activated yet, and for good reason. I don't think we want to remember what birth was like, because that's frightening. So You can't remember that because the hippocampus is not there, but the amygdala is there. And the amygdala is remembering things. The amygdala is memorizing things. So let me give you an example. So let's say at age 2, you experienced a house fire. Your house burned down. It's a terrible thing. Pets died. Maybe someone died. You don't have any memory of it. You don't have an explicit memory of it. You don't have a videotape in your head saying, oh, I remember where the fire started by the Christmas tree or whatever. You don't have that memory, and for good reason. It's a traumatic event, right? But the amygdala remembers certain characteristics of it. So you may have an extreme fear of fire when you're older, and you don't know where that came from. But the amygdala knows where that came from. It came from that fire when you were 2 years old. You can't remember. You don't have any smell, you don't have any sense, but you know you don't like fire. Well, that's the amygdala's job. That's called implicit memory. The explicit memory, which is really produced by the hippocampus, matures around age 3, 4, or 5. That's why when I ask you, what's your first memory? You may say age 4, you went to an amusement park with my grandparents. Okay. The hippocampus has matured at that point, and you can start remembering things. Again, the amygdala processes those highly charged emotional events. The hippocampus puts events into time, into space, into context. It stores your memory. It is suppressed during stressful, traumatic times, right? Now, for good reason, as we said, because, at the moment you've got to get out of that. You've got to get out of that ground zero right there. You can't sit and think, what's going on around? No, get out for your physical safety. That's why the amygdala kicks in. Again, it was part of when we crawled out of the primordial ooze, when we evolved, it was the first part of the brain that we had. And because the world was a scary place at that time, we don't want to become eaten by a saber-toothed tiger. So we ran, or we fought, or we threw a rock at the tiger. That's what the amygdala was doing. The hippocampus, as its job is to put things into order, can be suppressed during traumatic events. However, repeated suppression of the hippocampus can cause issues down the road. With suppression, as I said before, the organs are flooded with cortisol, and too much cortisol can cause faulty recall, flashbacks to the events, and the sense that the event or that danger of the traumatic event is not over. Again, the limbic system produces that cortisol, which is used to return the body to equilibrium, your breathing rate, your heart rate, your blood rate, whatever. And what we've seen in people who have been traumatized over and over again are increased levels of cortisol. It leaves markers in the body. What it can do is affect the nerve endings in the brain. What it can do is affect psychological development, emotional development, learning development, things of that nature, simply because it burns out the nerve endings in certain areas of the brain. And we can actually, if we're working with someone who's been victimized by abuse over their life, we can see these elevated levels of cortisol, and we can make direct correlations to if they've had issues in learning, behavior regulation, relationships, things of that nature. We can pretty much pinpoint that cortisol was the culprit. Let's talk a little bit about the reaction of freezing, flight, fight, where that comes from. So we know that freeze, faint, fight, and flight are the 4 reactions that we have when we experience a trauma. Freezing is the body's response to playing dead. So when a possum plays dead, that's freezing. We'll do the same thing too. I'm sure many of you know people who, in the midst of a disaster, crisis, traumatic event, just froze. Right? And that's the body's reaction. It's almost like dissociation, like going out of their head. Many times you talk to people who have been repeatedly traumatized or who have been in war zones. Combat vets will say that they know guys who just froze, right? Fellow soldiers or whomever who just froze. And what we think that is that you're getting out of your brain. Your brain is saying at the moment that this is such a horrible event. You don't really need to feel all of this. I don't want you to feel this pain that you're going to feel by observing this. And you literally go out of your mind. I've worked with abuse victims over the years who said that whenever they were being abused, they did not feel like they were in their body. They felt like they were actually watching the abuse take place from a corner of the room. And that's part of that freezing issue. The flight is obvious. You run like crazy to get away from someone or something or a traumatic event. The fight, if you're trained as a combat vet, that's what you do. Or you can faint. It can be so overwhelming that you just pass out. We do know that people who experience stress and or trauma in their formative years in the childhood, we know the developing brain is extremely sensitive to trauma and stress, much like the developing brain is extremely sensitive to other issues, smoking, drinking, taking drugs, things of that nature. We know that in children, traumatic stress can um, uh, stem from child abuse and or neglect, witnessing family or neighborhood violence. So if they grow up in a violent situation, if they have poor or incomplete attachment to their caregivers, in other words, if their caregivers are not able to take care of them properly, we know that this chronic stress will alter the brain development. Increased levels of cortisol can burn out nerve endings, which can make it almost impossible to develop in an appropriate manner. We also know that the coping mechanisms that were used to sort of blunt stress and trauma in childhood may be used in adulthood. So if you see someone your age sucking their thumb, you see someone your age who cannot react appropriately to anger and or stress or stressful times at work, that could be an indication as well too. In other words, they didn't emotionally develop. And they may be 40, 45, 50 years old, and they react to even the smallest stimuli at work in an inappropriate manner. That could be an indication. I'm not saying it is, but there are correlations that strongly suggest that they may have had some trauma in their early life that they never really resolved. So what are the symptoms of trauma? So we give you these so that you can observe these in the people you're helping or in coworkers. It's extremely important to understand the levels of stress that you as first responders are going through, but you also have to make sure you're observing it in your coworkers as well too, because if you're working on a team, you want to make sure everybody's in good physical and mental health as well. So here's some of the symptoms of trauma that you may see. You may see hyperarousal. That is that feeling that something's just not right, something's not over, the event is not done, the trauma is not finished. Constantly on guard, constantly on watch. You're expecting something terrible to happen. That's hyperarousal or hypervigilance, they call that. There's intrusion. People cannot shake the thought of what occurred. They can't get the memory out of their head. They may experience flashbacks. The flashbacks, as you may know, are not just a replay of that videotape in your head. A flashback is a feeling that you're actually back in the trauma. Where we most likely saw that was in the 1970s when veterans were returning from the Vietnam War. And if a car backfired, they took cover because they were back in the rice paddies. They were back in the jungle. It wasn't just a memory. It wasn't just a recording in their head. They actually felt as if they were back in that combat zone. That's what a flashback is. So if you're working with someone, that person may feel like they're still in that house, which is collapsing because of a fire, or they're still in that car accident. There may be emotional constriction, where people just feel numb. They may dissociate, as I said before, sort of go out of their head. They may feel like they're in limbo, they're in a cloud, they're not really attached to the world itself. It's that unreal feeling. So it's a disconnect between events and a disconnect between what the meaning of those events are. It also is a method of control because most human beings want control. If I can control my emotions, things will be okay. So they may deliberately try to withhold emotion so that they don't spill all over the place or sort of act inappropriately. There's avoidance behavior. And we see this in responders who may be affected, and maybe they had a traumatic event at a particular job, whether it was a fire, a car accident, something involving a child, and they may not want to do that again. They may try to avoid doing anything that relates to the traumatic event. So if you went on a job where a child was killed, let's say, you may react negatively to children the rest of your life because of it, or try to avoid doing anything with children because you don't want that brought back up in your mind. So these symptoms are the ones that are most occurring with traumatic events: hyperarousal or hypervigilance, intrusion, emotional constriction, and avoidance behavior. So if you're working with survivors, or you notice your coworkers may be experiencing some traumatic events or traumatic reactions, as it were, this is what to look for. You can maybe look for these mood swings. The morning they're great, take a break, and all of a sudden they're depressed or they're angry or they're upset. And it can happen throughout the day. So it can be very high, very low, very high, very low. There can be short, intense bouts of severe depression. And what a severe depression looks like is they can't get up. They can't get away from their desk. They can't get out of the truck. They may just be miserably down, black, bleak. If you're working with them in an office setting like I do in my own practice, there may be an experience of severe emotional distress when you're talking or working with them that doesn't resolve by the end of your meeting. If you're working with them and you're meeting with them, but they may be in such emotional pain, and it just comes across them suddenly. They may act out with aggression. Okay. They may get really angry with you. They may dissociate while talking, and all of a sudden you'll just see a disconnect, and you'll see a look come over their face, and they're moving away. So if you notice this, these are signs of what we call affect regulation, where their mood, the way their face looks, changes. Okay. Now, if you're working, if let's say you're a peer support specialist, let's say you're a clinician like me, let's say you're working um, with responders or you're working with survivors, what do you look for in sessions? Well, some of the challenges that you might have is that we know that you can have a company exposed to a traumatic event, right? And there may be some people in that company who are severely affected by the trauma. There may be some who are not affected by the trauma. And you say to yourself, how does that happen? Why is that the case? Well, what we found out is that the more support you have, the better you're going to do. Now, that's easy to say. The more support you have personally within your agency, your company, coworkers, if you will, family, friends, the community itself, socially, the more support you have and the more support you access, the better you're going to do in processing the trauma. And that goes into therapy, counseling as well. So if you take advantage of all of those supports, you're going to do better. So the responder who has an intact family, which is supportive of the work he or she is doing, they have colleagues, a really tight group of people they work with and they appreciate. Maybe they coach in the community or they are involved in the community in some sort of activity. And maybe they visit a counselor or a therapist on a regular basis. They're going to do a lot better than that person who basically says, no, I don't need any help. I don't talk to anyone about this. This is just for me. This is what I do for a living. That's that old suck it up mentality that we're trying to push away, right? Because suck it up. And see, the interesting thing with emotional reactions is that they're going to come out one way or the other. And you can stuff them and stuff them and stuff them and stuff them, and you can stuff them and stuff them more, and you can drink and drug and do everything you can to forget it and put it in that corner of your mind. Those reactions are going to come out somewhere, somehow in your life. This is empirical. We've studied this and we've seen this happen before. So the more support you have, the better you're going to do in processing trauma. We know the same event can engender different symptoms. And some of the symptoms that we see are anxiety, creation of anxiety, depression, a worsening of other physical symptoms or emotional symptoms you may have. We see substance abuse coming out of this a lot. We certainly have seen opioid abuse because people get injured on the job and they take opioids, and we see that substance abuse or dependence occur. Um, we see post-traumatic stress disorder, certainly, or acute stress disorder come out of it as well. We know with post-traumatic stress, there's a high comorbidity with that and other disorders, and I'll explain it. Post-traumatic stress disorder, interestingly enough, prior to 9/11, you had to have the symptoms of post-traumatic stress disorder, the anxiety, the depression, hypervigilance, arousal, the intrusion. You had to have those symptoms a good 90 days or 3 months after the event. What happened with 9/11 is we started to see those severe symptoms develop within 1 month. So the American Psychiatric Association changed the diagnostic criteria to 30 days as opposed to 90 days. So in post-traumatic stress disorder, not only do you see the hyperarousal, the intrusion, the emotional constriction, the flashbacks, but we see comorbidity with anxiety, depression, bipolar disorder, substance abuse issues as well too. Because with substance abuse issues especially, people are trying to self-medicate. Well, I'll just have a few drinks, I'll calm me down. 2 drinks becomes 4, 4 becomes 8. Next thing you know, you're dependent upon alcohol. You may not be, if you're working with a coworker, or maybe you're doing peer support, you may not be aware of the traumatic event simply because the person didn't reveal it to you. Well, my company commander told me to come in and talk to you, so I'm here. Okay, what happened? Well, nothing, everything's fine. They may be ashamed to tell you. And this is not uncommon when you're doing trauma work, because a lot of times people, when they're traumatized, they find that they'll say to themselves something along the lines of, well, I should not have responded in the way that I did. I do this for a living. I should not be traumatized by that. And we know that there's always some sort of trauma out there that can affect someone. No matter how prepared we are for it, it's a psychophysical reaction which is seen as overwhelming. We're going to have those in the course of our life. We also need to know if there's multiple co-occurring traumatic events. We call this complex trauma. So let me give you an example. Let's say you're a responder, and let's say you may have a previous trauma in your life that you never really worked through. So let's say it was a death of a child. Maybe one of your cousins passed away whom you were close to, or a friend when you were a kid. Okay? You go out in a job and a child is injured, a child is hurt, or God forbid, child dies. That may cause another reaction in you. So now you have trauma on top of trauma on top of other trauma. If you don't resolve the one trauma, when you're traumatized again, it's going to make it more complex and compound the issues. So if you're working with someone, you need to know what other traumas they've gone through as well too, and you need to see if the people are comfortable in talking about them. So if we're working with a coworker or a survivor, what do you consider? What are the first things you should do? The first thing is you have to maintain safety. If you're doing critical incident stress management or stress debriefing, you have to make sure it's in a safe place. If it's near the disaster, or it's not back at the agency, or it's not back at the garage or the house or whatever, you make sure that there's the risk and safety issues. The risks are taken care of and the safety issues are taken care of as well too. You got to ensure safety and stability. If you're working with someone who's been traumatized, they want to know that you're going to be there for them. The relationship we look for is trust. Now, as a clinician myself in my own office, I've worked with clients and patients who've been traumatized. They may not feel safe for a year or longer. It can take a long time to build trust, depending upon the level of trauma and the experience that they've had with the trauma. The information that you want to gather, basically historical, mainly reactions, things of that nature. There's no judgment involved when you're doing trauma work. We're here to listen. We're here to validate. We're here to just get your opinions as to what happened. The observations that you want to make are clearly, as we said earlier, affect regulation, their behavior in session, their manner of responding, things of that nature. Are they dissociating? Are they with you? Are they conversational? Are they able to stay on task? The diagnostic tools, if you do use them, we try to make sure that they're short, they're focused, and they're not too invasive. You don't want to give someone a 1,000 question survey about their feelings because number one, they're going to think that you're trying to really overanalyze them and dive deeply into things when they just really want to talk about what happened. So you want to keep it short, focused, and to the point. So that's individual trauma. Let's talk now about more in-depth traumatic reactions as to what can happen to people um, emotionally, psychologically, cognitively, and physically as well. So some of the pictures I have here are when we went to Chile a few years ago. In the university, we went down to speak with first responders and social workers about emergency response in Chile. Um, and consequently, right before we visited, there were a number of wildfires, which took out a large part of a community in Valparaiso, Chile. Valparaiso is a coastal town surrounded by 7 hills. And in these hills, there are, for want of a better phrase, squatters or shanty towns, which are really sanctioned by the state. People build homes out of materials that wouldn't pass code in many countries and many communities. So you have a lot of pallets, you have a lot of corrugated metal. There's no running water. Electricity is there. There's no gas or heat or utilities in that sense. So people use a lot of propane. Um, Running water is really gathered by cisterns. Um, so what happened was there was a fire near what happened, I believe it was a vulture got shocked on a high tension wire, fell into the eucalyptus trees below the power lines, and eucalyptus are very oily, started these wildfires and took out about 15,000 homes and killed a number of people in the community. So we went down there to talk about community resilience and see how they recovered. But we also noticed a great deal of community involvement, and we'll talk a little bit about that as we go on. So a lot of these pictures are from our time in Chile. So we know that traumatic reactions, what happens in the wake of a trauma to people? Well, we know that there's developmental trauma, as we said before. A lot of cortisol buildup in the brain can cause certain reactions. And the developmental trauma that buildup of cortisol can cause are issues with attachment. They may not feel close to people closer to them, whether they're parents, caregivers, spouses, whatever. There can be issues with biology, certainly with uh, the biological reaction of excreting hormones in the brain, mood regulation, as we talked about earlier, dissociation, issues in behavior. Their behaviors may spike. Their for want of a better phrase, their acting out behaviors may spike. They may have issues with cognition. In other words, they may not be able to stay focused on a topic. They may not be able to think appropriately. They may not be able to work through issues or work through simple problems. And we know that trauma can cause issues with self-concept. As I said earlier, people, well, I shouldn't react this way because I'm a first responder and I've been trained. Well, that's self-concept in and of itself. So we'll go through the reactions that they have. Cognitive reactions themselves talk about confusion, disorientation. Post-disaster with survivors, we talk about fear of separation from family or pets. And I've done that, that kind of work with people who have experienced disasters and have felt that they cannot be away from their family ever again. They don't want to leave their spouse. They don't want to leave their parents or brothers or sisters. And even if they go to a store, let's say, they go to a large department store and they're on the other side of the store, that can engender a confusion or disorientation or fear, if you will, of being separated. They may have those recurring dreams or nightmares. We talked about flashbacks, but we're talking about dreams or nightmares here, things that wake them up at night. And then, of course, you have the attendant sleep disorder that comes with that as well, too. There may be a preoccupation with the disaster. We saw this a lot in 9/11, where people were just preoccupied with news stories about it, and people had maps laid out in their homes and just tried to make sense out of what happened. Um, they're looking for answers that aren't there. They may have trouble concentrating, excuse me, remembering things or making decisions. We see this most often with children who've been traumatized, right? They go to school and they can't focus on their work. Well, at that moment, algebra homework may not be the most important thing to them. The confusion or fear that they have from being from their families might be. A lot of times we work with people and they question spiritual beliefs, right? How can a benevolent Lord or God cause this sort of thing to happen? There are behavioral problems as well. So we talked about the thinking issues, the cognitive issues, behavioral reactions. And what I did with this runs the gamut from children to adults, infants to adults, if you will. There's sleep problems, as you said earlier. So the nightmares may cause sleep problems. And we know that if you don't get decent sleep, you're going to react negatively in many cases. People may cry easily at the drop of a hat, if you will. People may avoid reminders of the disaster. And this is especially important around anniversaries, right? Um, and I would also say that anniversaries of trauma. If your trauma occurred in the wintertime, pardon me, you may act out or become depressed during the wintertime in subsequent years. The sun sets earlier, you may become more upset as the sun sets earlier and more depressed. And that's simply a reaction to when it happened before. So it's sort of an anniversary reaction, if you will. Interestingly enough, some people may withdraw, but some people may experience an excessive activity level. So they may jump into other things, basically to keep themselves preoccupied and to avoid any reminders of the disaster. They may have increased conflicts with loved ones. And people who were supporting them before, they may start acting out of that towards them. We mentioned hypervigilance and startle reactions. People were easily startled. I mentioned the isolation, social withdrawal. Some people just go into the room and don't want to come out. There's that focus on the disaster and worry that another one will occur. When we were in Chile, I remember talking to someone who said that the wildfires had occurred during a particularly cloudy day. And he said, whenever it's cloudy, I start to worry, and I don't know why. And that's simply because he's equating the clouds with the wildfires where people he knew died. You may lose interest in your usual activities. For children, it might even be playing with their friends. Again, they withdraw. Um, People may return to earlier behaviors, as I said earlier. So thumb sucking, baby talk, bedwetting, tantrums, things of that nature. With teenagers, we see an increase in risky behavior. So they may drink or drug, or they may drive erratically or drive too fast, something along those lines, or do things that they've never done before. We know that there's physical reactions as well, too. And as trauma engenders a psychophysical reaction in people, there's fatigue, exhaustion, which makes sense. There's gastrointestinal distress. You may not want to eat. You may just, you can't eat anymore, or you may eat too much. Sometimes people use food to self-soothe. You may feel that constriction in the throat, tightening in your throat, your chest, or your stomach. It might be more difficult to breathe. If you have existing medical conditions, diabetes, asthma, high blood pressure, you may experiencing a worsening of those symptoms as well, too. And there's other issues we call somatic complaints. So body ache, pain that you've never had before and you can't figure out where it's coming from. That may occur as well, too. So how do you work with people who have been traumatized? What kind of work? We talked about earlier the considerations you may have. But how do you work with people in this sort of a setting? Well, we work on what we call psychodynamic or trauma-focused therapy. We know that cognitive behavioral therapy is good for it. And I'm trained in cognitive behavioral trauma-focused therapy, and I'll tell you a little bit about each of these, or just trauma-focused therapy. Excuse me. In psychodynamic trauma-focused therapy, what you're trying to do is to establish a relationship, a trusting relationship. And as a psychodynamic therapist, I want to know everything about your background. I want to know everything about your family. I want to know your history. I want to know where you come from, what you think about things. You try to find out the whole person, but you want to do it in a way that is developing trust, developing comfort, and letting the client go at their own speed, because that's important. The person who has been traumatized is the most important person in the room. Their perception of the trauma is what counts. So my job in working with them in this manner is to develop that trusting relationship, but also having them feel at ease to share what in their mind really happened. Excuse me. In cognitive behavior trauma focused therapy, what you're trying to do is to examine the thought patterns that they have about the trauma. A lot of times, whether you're a first responder, whether you're a survivor, a lot of times people may think that they caused the trauma themselves. Um, that's not always the case. Sometimes people think, well, because I was a bad person, I caused it. So one of your jobs as a trauma-focused cognitive behavioral therapist is to get those thoughts in line and to change that thinking and to have the client see that that wasn't really the case. But what you're also doing is you're focusing on the thoughts about the trauma itself. Um, where a lot of this came from, just parenthetically, especially in child abuse cases where kids blame themselves for being abused. And that's where you try to change their thought patterns. But, there's also other disasters and crises that people respond to, that responders respond to, that people think, if only I didn't have an argument with my spouse this morning, I would have gotten in that car accident and I wouldn't have killed the kid, whatever, that sort of thing. So that's one of the jobs that you have as a trauma-focused cognitive behavioral therapist, is to change that negative thinking pattern. Or in trauma-focused therapy, we're just focusing on what happened and try to establish a sequence of events and what happened in a timeline, and to try to focus on each issue as it comes up. You can work through trauma with psychotropic medication, although most studies show that psychotropic medication alone cannot resolve the trauma. It has to be in conjunction with talk therapy. So thought patterns, perceptions, self-concept, things of that nature, along with psychotropic medication. So whether it's an anti-anxiety medication, whether it's an depression medication, um, a benzodiazepine, which are fallen out of favor, and rightfully so, because they're highly addictive. But those are the ones that have been most often used in the treatment of trauma and the resulting anxiety and or depression. There's exposure therapy, and this is for people who are having trouble avoiding. We're not trying to, who are avoiding any kind of memories of the traumatic event itself, especially if it impacts their daily life. If you're a first responder and you're trying to avoid any remembrance of fire, that could be difficult. So this is where that would be indicated, where you try to work through the event itself or the event that caused the issue itself, and to try to expose yourself gradually back to the event, and do it in a way that's favorable to you, where you don't become oversensitized. There's relaxation therapy, which, interestingly enough, a lot of people have to learn how to relax, right? Just as we say, one of the things we talk about nowadays is self-care, right? And a lot of people talk about self-care, but a lot of people don't know what self-care is. So relaxation therapy would teach you how to relax your body, how to relax your mind, how to relax your thought processes, things of that nature. Creative arts therapy is interesting too. This is good for people who don't have the ability to express themselves well, but can express themselves through any kind of art, whether it's writing, painting, photography, acting, drawing, anything along those lines. When we were in Chile, one of the first things that they did was in the communities which were burned out. One of the first things they did was rebuild the community centers because they wanted the children to have a place to go. And they rebuilt the community centers immediately. The children went there and they just said to the kids, paint murals, and let's, whatever you guys want, you dress it up the way you want it. These kids drew murals, painted murals of the fires themselves, but they also painted murals for the community. It was very therapeutic for them. So that creative art piece got them out to express what they were going through. A lot of kids don't have the intellectual capabilities because they're just not developed yet. But by painting, by expressing themselves in other ways, it's very valuable. So again, if you're working with someone who's been traumatized, whether they're a survivor, whether they're a coworker, and as I said, if you're a peer counselor, you want to establish that sense of safety. They have to feel safe when they're talking to you. You want them to be able to regulate their affects so you don't have that emotional up and down, right? So let's see if we can talk about the event in a way in which you're comfortable. Okay? We want to reestablish attachment. And what do I mean by that? We want to get them back with their support systems. Again, as I said before, it's one thing to have a support system. It's another thing to access it. All right. So we want to make sure that they know they can rely on people and they can rely on their supports. We want to enhance the brain's executive function. That's the cognitive piece that we talked about earlier. We want them to have the ability to think, to make decisions, to make appropriate decisions, and to sort of reflect on their decisions as opposed to just making a rash decision, but to think about, critically analyze what they did, evaluate what they've done. We try to reframe and integrate the traumatic experience. Many people, if I'm working with them and they've been traumatized, the trauma identifies them. I'm a child abuse survivor, as opposed to, I'm Jane or I'm Bobby. No, I'm a child abuse survivor. Okay. How does that define you? If it defines you in a negative way, we want to be able to reframe the abuse, not minimize it, but reframe it in a way that, you know what, you weren't at fault for this. This was not your responsibility. This is something that happened to you. And we want to integrate it in a positive way so that they can say, that's why we use the word survivor in many cases as opposed to victim, because survivor suggests empowerment and resilience. So that's why I appreciate in first response the people who go through a natural disaster, a man-made disaster. They're survivors, right? They truly survived a horrible experience. So a lot of times I'll ask several questions. Where do you feel safe? A person says, I don't feel safe anywhere. Then we've got some work to do because that sense of safety is essential. I have to have a place to go. That's why people withdraw. They feel safe in their bedroom or their den or their office or wherever. That's why people withdraw. They feel safe there. So where do you feel the safest? Who do you feel the safest with, right? What do you do to feel safe, right? Where do you feel the safest? In my bedroom. Okay, great. Who do you feel the safest with? I feel the safest with my teddy bear. Okay, okay. What do you do to feel safe? I go on, get under the covers. And that's fine. But if that's all your life is, we want to make sure that they can access those support systems. So we ask these questions to get an idea of what they like or what they like to do. Okay. When we talk about regulating affect, it's important to address the body's response to any kind of stress or trauma. All right. If we're traumatized, if we're totally what we call bottom brain driven, that means the amygdala is in charge. If we're letting the amygdala be in charge all the time, we're going to respond in a hyper emotional manner. And that's going to prevent rather the cognitive processes. Remember what I said, when the amygdala is in charge, everything else gets shut down. So rational thought in this part of the brain, the prefrontal cortex, where all our thinking and memory is stored, that goes out the window. So if you're reliving a traumatic experience, you're going to react traumatically, and you're going to react from that bottom brain. So we want to get that normal expression of the cognitive processes out again. We want to be able to have these victims or survivors. We want to have them regulate those reactions. Okay. We want to have them to have the ability to say, no, I'm not going there. No, I'm not going to react that way. No, get away from me, trauma. So I'll ask folks who've been traumatized these questions. If you could rank your trauma from big to small, what is it? How big or small is it? If your trauma could talk, what do you think it would say to you? I control you. I caused this. What does your trauma say? If your trauma could listen, what would you say to it? Because that's very powerful. If we give people those license or those tools to say, hey, trauma, go away. Hey, trauma, shut up. Hey, trauma, hit the road. I'm done with you. That empowers people. Again, reestablishing attachment. We want to identify those institutions that are supportive to them. Okay. We want to make sure that they access therapy, or they access a support group, or they access a group at work or something along those lines, and that they continue to build a supportive network. They may have to change a routine. Maybe they start going to the Y. Maybe they start doing something differently, and that's okay. But at the same time, we want them to strengthen friendships and develop peer support as well too. So as I said earlier, the more support, the more attachment you have, the better you're going to do with trauma. I have here provide youth with opportunity to discuss disaster-related events. And this came out of Chile. And what they did in the community centers was they had the kids come in once a day and just talk about what happened. And it was very therapeutic for them. So it also had the children in the community pick up from their peers, why peer counseling is so important and why we stress it in critical incident stress debriefing. To sit around with your peers and discuss what just happened is powerful because you're getting perceptions that maybe you didn't have. You're hearing things that maybe you didn't think about before regarding the event itself. But also they're relying on each other to solve problems, and they're developing coping skills for it. You know, hey, what do you do when the thoughts become so overwhelming? What do you do if you're having nightmares? That sort of thing. Resiliency is a concept that we'll talk about, and resiliency is basically the ability to snap back or bounce back post-disaster, okay, or post-trauma, if you will. And what we do when developing resiliency is you have to depend upon one another for everything. We went to Puerto Rico in the wake of Hurricane Maria a few years ago, and what we noticed was the communities there, the ones that did better in recovery were the ones who had great community activity. In other words, the members of the community supported each other in rebuilding rather than wait for emergency management agencies to come in. They jumped into action right away and helped each other. Those communities did better. That's what we're talking about, support and attachment. The community members there took decisive action. They started clearing debris out the minute the rain stopped. Okay. And instead of blowing the event out of proportion, in other words, they didn't wring their hands and cry. And well, there was obviously sadness, but they got right up and got to work. If you had the physical ability to do it, you pitched in and you helped out each other. And those communities did better. Again, I can't stress the need for support, the need for action, and the need for attachment in the wake of a disaster and or trauma. What we found is that if people talk about it, it reframes and integrates that experience itself. Give survivors a voice. Let them talk about it. Don't tell them what happened. Have them tell you what happened, okay? Because we know that this becomes a part of their life. And rather than becoming all of their life, we just want it to stay a part of their life. It doesn't define their life. It doesn't define who they are. And by talking about it, they can start to make sense out of what happened. It may answer some of those unanswerable questions. And it gives them the ability, what I call, restory their own life. Don't read the news accounts about what happened in your community. Tell me what happened to you in your community. We know that there are issues associated with disasters as well, too, that are related to trauma. And these are some of the pictures of the communities we visited in Valparaiso post disaster, post fire. We know the emotional and physical exhaustion that we talked about. We know there's survivor guilt, not only with survivors itself, but with first responders, especially if there's a death of a colleague. Why did she, end up dying and I didn't? That sort of a thing. And there's fear and anxiety, especially if you're going out on another job right in the wake of another, the next day you go out, you don't get a break, right? You go out the next day and you might have to go to another job. There's lingering distress. Again, that sense that something bad is going to happen again, and I still feel bad about what occurred. And that takes a lot out of you, emotionally and physically. A couple of things. We talk about special populations, and we'll talk more about vulnerable populations in subsequent presentations, but we do know the data is out there that climate change intensifies the vulnerability of many communities. As we talked about, we've got wildfires all over the country, and Australia had this horrible fires a few years ago. We've got increasing weather-related disasters that are occurring. And we found out that in other populations, such as youth, their mental health is particularly concerning post-disaster, especially nowadays in the wake of climate change, because they're going to inherit this earth. And what are they going to do about it? So there is a lot of fear and anxiety out there. We also note that in the wake of many natural disasters, there's been a great deal of post-traumatic stress noted in younger populations. So that's something that we have to think about. We know that not all symptoms resolve over time, right? There are still people who are feeling the effects of Hurricane Katrina and 9/11. Again, if you've been previously traumatized, if you've had previous health problems, behavioral health problems, if you've had previous issues with violence in your neighborhood, these could make you more vulnerable to trauma. And what we need to do to prepare is to understand the populations with whom we're working. This is not a template that says this is going to fix everything. Every person who's been traumatized is going to respond differently. What we've given you today are just sort of an overview, and we can expect these, or we can expect fewer of these or more of these in each person we work with. Okay. So again, to sum up, if we're working with people who've been traumatized and their traumatic reactions, we want to provide perceptions of safety and security. You can come and talk to us. This is safe. You're safe here. It's going to be fine. Discuss feelings and concerns, right? We're going to correct misperceptions and offer reassurance, all right? We try to get people back to predictable activities and normal routines. Hence, in Chile, the community centers and the schools are the first things to open. Provide and maintain those supports. There's interpersonal connections. Don't withdraw. Don't withdraw. It can feel good sometimes, but you cannot stay in your room 24/7. Encourage healthy behaviors, obviously, right? One of the things that we talk about post-disaster or post-trauma is, especially in community disasters, parents and caregivers have to model appropriate behaviors and coping skills for the children of the community, right? So if the parents are out drinking and drugging and driving like mad, the kids are going to pick up on that. They're going to feel unsupported, or the kids may do the same behaviors. So we need to educate communities about that. We want to reduce exposure to events that increase stress, certainly, right? We want to make sure that they're doing things or participating in things that are appropriate and proactive. Encourage participation in less stressful events. Get involved in the community. And every agency needs, or every community, I should say, needs to develop a response plan that addresses the mental health impact or the psychological impact of trauma. This is critical because if we, I'm going to talk about it later. And for every physical injury in a disaster or a crisis, there's something like 25 psychological injuries. So think about that. There's a lot more psychological mental health injuries than there are physical injuries in any kind of disaster. So it's critical that we address that in our disaster planning. And I end with this: the trauma stays with us, even though the trigger may appear to be out of sight. So that traumatic event may be gone, the site may be cleaned up, whatever, it's gone. But that's going to stay with us for a long time, especially if it goes untreated. So thank you for your time. In Module 2, we'll be discussing crisis intervention and de-escalation of survivors. Thank you.